Welcome back to 90-Day Dental Day 15. So, we've gone through smile design, we've gone through the principles involved and the early stages of treatment planning, and the next logical step to tackle is to go down the route of occlusion, which is we've split into two parts. One part we'll be covering today and the next part we'll be covering tomorrow. A superb session with Gary DeWood coming up right now.
Hello everyone, nice to be back with you at 90-Day Dental. Ahmad, thank you for the invitation. Today what I want to do is talk about occlusion, and I'm going to divide it into two things. I'd like to talk about occlusal design. And occlusal design is kind of smile design with teeth, if you will. Let's make those teeth work. Part one about that is occlusal analysis. So I'm going to show you three words. These three words all rhyme. If you've been in dentistry for very long, you understand why those three words have meaning when they're together. And that's because all of this stuff was very confusing. And it was easy to get into a delusion that everything that I said was right. Here's some things that I've learned. We have to ask ourselves, what questions do we need to answer about occlusion? Can I use the existing occlusion, and can I be safe and successful? When must I equilibrate? If I change the patient's existing occlusion, what is going to happen? If I totally change it, where I remove all tooth contacts, how do I recreate that? I was searching for one right answer. I'm going to bet that most of you at some point in your career were that. I wanted everything to be black and white. Just tell me the way to do it so I'm always right. And the four things that I had to hang my hat on around occlusion were these four: ethology, neuromuscular, bioaesthetics, and then Pankey-Dawson. Okay? And all of those concepts were successful, which is interesting to me. They all work. Well, the problem with they all work, if I'm looking for black and white, is that I'm right back where I started, is if they all work, which one should I use? So maybe we should ask another question. And I first heard this question posed by Frank Spear, who I am really fortunate and happy to be able to get to spend a lot of time with these days for the past dozen years. It's been fun because he said, maybe the question should be, when will an occlusal approach not be successful? So if I took all of those and I added one more, maximum intercuspal position, which is where most people are, where most people function, how do you know it's not working? You know it's not working because of those things, of signs and symptoms. Symptoms are things a patient experiences. Signs are things that you and I can see. See, here's the difficulty in my life. I said there's one ideal occlusion. There's one right occlusion. There is one natural occlusion. And once I examine you, okay, if your occlusion doesn't match that right occlusion, you are going to get treatment. Now, that treatment may be very successful. It might even have been necessary. But I learned over the years that a lot of people that I was worried about their occlusion seem to be doing just fine. Why have multiple approaches proven to be successful? That's because of adaptability. Patients have a range of adaptability. As long as their occlusal scheme, what's happening is within that range of adaptability, they're going to be asymptomatic and asynomatic. Okay, sometimes they're just asymptomatic, which means that you and I see signs that show that's not working. That's when patient education becomes a very important thing. Okay, patients who want to keep their teeth want to know about that stuff. When the occlusion is outside that range of adaptability, they're going to be symptomatic and cynomatic. There's a problem with adaptability, okay? There are so many different thresholds. If I think about this, every patient has their own threshold. The range can change for each patient. I'm old enough to remember sending kids off to college and having them come back and saying, I'm having all these problems. And in fact, they were patients who had been totally fine in all the time they were growing up. Something changed. Something adaptability-wise changed for them. And all the things that started to show us that it's not working, all of a sudden, some of those became evident. I hope not all of them. My goal was to try to put that occlusion back into that range that allowed them to be comfortable. I discovered that occlusion has to be highly individualized. Step one is to look at muscles, joints, and teeth. So if I think about joints, I have to figure out what's happening inside that joint. The joint is what allows the movement to happen, okay, and the load. What muscles hurt? What movements are limited? What function is altered? Those are the things I have to ask myself. If teeth aren't in the way, I know the mandible is going to go to some seated position. Is that a position I should start with? That's a reference. In my early career, what I used to do was I said I have to get people to centric relation. I learned that actually my job was to find a reference I could start with if I had to do something. And then today, what I believe is I prefer to work from central correlation because it's a repeatable point I can plan from. I'm no longer that zealot who said I have to go in and equilibrate everybody so they're at central correlation, because I found out that a lot of people were just fine if I didn't. Now, here's what I know. If joints are fully seated and people close, they sometimes hit on teeth like this, which means that all their teeth aren't hitting. Okay, less than 20% of people when their joint is fully seated are going to come up and hit, and that's from a number of articles in the literature. Well, let me say it another way. 80% of people are going to have some sort of a shift from that fully seated joint position out to where all the teeth work against each other. Muscles have to position that so that it happens. I'm going to want to look at muscle. Okay, with teeth I have to look. Where is the sensitivity? Where is the mobility? Where are the cracks? Where are the fractures? Where is the wear? That tells me what people are doing with their teeth. All of those things are things that I have to bring into my mind before I can answer the question. Is this working? People with their teeth together in 4 places: maximum intercuspal position, excursive pathways anterior or lateral to MIP, end-to-end and crossover, and then occlusal contacts retruded from MIP. And that crossover, the end-to-end, is the crossover that's included there is a protrusive crossover, because side crossover, lateral crossover, is actually an end-to-end type position. Okay? What do people do at MIP? They do those things. They chew, they swallow, they clench. Excursive pathways, they chew, they talk, and some people do dysfunctional things there. How about end-to-end crossover? People incise things. Speech isn't really involved with where those teeth are, and they do dysfunctional things there. Mastication, swallowing, and dysfunction happen at a fully seated condylar position when you can get it. 20% of people aren't going to have this one. Well, it depends on the literature. I'd say it's more like 10%. Okay, because the literature, actually the outliers went to 20. We use 20 to say, yeah, 20% of the time it could happen. 80% of people are going to be able to have their mandible fully seat, and they're going to hit on some teeth before they go to that fully intercuspated position. They have a seated joint. Okay, we call that centric relation, although I hate that word because it's so full of stuff. All right, and we look at what happens and we say, well, okay, those are retruded contacts. People do stuff back there. We have to decide, is this a physiologic or a pathologic occlusion? If it's pathologic, I would ask this. Here's what I see happening in a pathologic occlusion. I have to ask myself, how am I going to alter it? If their occlusion is physiologic, I would ask, why would I ever alter it? In other words, if it's working, no matter how they're hitting. If dentistry is required, I have to say, where will dentistry be completed? In other words, where am I going to alter it? Now, why would I ever want to own the patient's occlusion? Well, if it's physiologic, let's leave it. Okay, if it's pathologic, I can't. Some occlusions require dentist direction. Those are the pathologic ones. That's when the patient's adaptive capacity is exceeded by the rate at which the signs and symptoms are progressing, and the patient is ready, because they have to be ready for it. I need to own it because it ain't working. Ownership is also required if the changes to the teeth required for treatment for non-occlusal things would destabilize the first point of contact in that shift, which means that I have to check it. Will the occlusion be destabilized by the planned dentistry? Here's a seated joint. There's a first point of contact. Again, that first point of contact, there's MIP. If I'm going to treat both posterior quadrants on this side for that patient, can you see that that could be an issue? Because I am not going to be able to recreate exactly what was there. Here's a 56-year-old dentist, one of Frank's patients. Don't like my front teeth, want to lose my amalgams. He's completely comfortable, no pathologic wear. There's where his first points of contact are with the joint seated. He has a nice shift, but we're going to be treating those teeth. That means that spot has to tell him kind of where to go to. That's how engrams are developed. You touch somewhere and your brain says, well, no, shift. Will that be enough of an engram? Because when he bites, he can hit all those places, as you see on those dots. You can see from this provisional, because he decided as a dentist, let's leave my MIP where it is. It works really great. After the preps were done, he started breaking those. That's where he was hitting. His mandible seated and he went back there, which means that here's how that looks, okay, when he's forward, but when he goes back, can you see we don't have clearance? Have you ever experienced that with a patient? I have. MIP is forward, he goes back, all of a sudden there's no room. I have been there when this happened. What do we have to do? We have to say, well, if he comes out there, that's okay, but he's not going there. He's going backwards. So what do? We're going to have to change this. That wasn't enough to hold him there. We're going to have to re-prep and allow him to seat his condyle, and we're going to have to use that as our reference. so that we know we have something that is stable. The shift is gone. The shift was not removed because he was destroying things. The shift was removed because something changed. That's the risk if you use the existing MIP. The changes will disrupt the engram programming. You have to check it. So talk about risk factors with your patient when you see those shifts. Talk about what might happen. If you're treating more teeth further to the back, you have more risk because those are the teeth that get in the way first. If you have fewer teeth closer to the front, there's less risk. Now, once you decide that you want to own the occlusion, how should you design it? That's a whole separate question. And I'd like to answer that in part 2, because I know that these are supposed to be somewhere between 5 to 10 minutes. And when I go to that one, it's going to take more. I hope that you enjoyed that one, and I look forward to seeing you on the next one if you come back. Thanks for watching.